Good evening, ladies and gentlemen, and welcome to our Eating Disorder Hope webinar presentation featuring Dr. Mascolo and Dr. Lashen of the Acute Center for Eating Disorders. Our presentation this evening is on addressing medical and psychological complications of eating disorders. Before we get started with the actual presentation, I just want to point out a couple things to you. You will have the opportunity to submit questions to our presenters at any time during the presentation. Please feel free to submit those through the question pane of your control panel. We will be collecting questions and addressing questions at the end of the presentation during the Q&A portion. Also, we will be making available at the start of the Q&A portion, the link to your CE form that you can complete online and at the end of the presentation in order to receive your CE credit for this evening's presentation. So without further ado, I'd like to now transition this over to Dr. Mascolo.
Thank you, Jackie. Thank you for organizing this, and thanks everyone for joining us today. My name is Margherita Mascolo. I'm the Medical Director of the Acute Center for Eating Disorders at Denver Health. Dr. Lashen and I are excited to share with you some of the medical and psychological complications of eating disorders. We'll break up the session into two parts. We'll talk about the medical complications first, and then Dr. Lashen will take over and address the psychological complications. During the medical complications piece, we'll talk about the complications of restricting anorexia and how to manage them, the ones that are particular to bulimia and the binge purge kind of anorexia and how to manage them, and really recognize when patients need to be hospitalized and need to be at a higher level of care. So as far as the medical complications piece, I wanted to start by talking about mortality. Mortality in anorexia actually has the highest mortality of any psychiatric condition. It is about 12 times higher than the annual death rate for women that are 15 to 24 years of age. And the majority of deaths, we think about 30 to 40%, are due to medical complications. So it's very, very important to know and understand the medical complications of this illness. Another about 20% of these patients die of suicide, unfortunately. And sadly, about 30% of affected patients never achieve sustainable recovery, and this is why the readmission rates are so high, sort of across the spectrum. Although there is good news about that, one of the latest studies that came out this past year showed that from the beginning, from the diagnosis until cure or remission, the average time that a patient spends in treatment is about 7 years. However, the study has shown that up to about 22 years, patients can still recover. So it's very important to recognize these complications and treat them. So what are some of the risk factors of mortality? This is a list of them. The two most important ones are number one, lower BMI at first presentation, and number two, duration of illness. The combination of those two risk factors really speak to the severity of the illness and thus the higher mortality. What is the reality? In the U.S., about 20 million women and 10 million men suffer from an eating disorder at some point in their life. And this spectrum goes from the severe anorexia that we see here at acute all the way to sort of the binge eating and the obese category. But it's a very large population that has some kind of eating disorder. By age 6, girls begin to be concerned with weight and shape, and up to 60% of elementary school girls are concerned about becoming too fat, which is a really sort of shocking statistic. When I was that age, I certainly did not think about being too fat. So things are really changing, and it's a disease that affects very young patients. Preteen girls are more afraid of fat than cancer, and 45% of girls who smoke use it as a form of weight control, which as a physician, I'm an internist, is a horrifying statistic because that sets them up for a lifetime of medical complications that have to do with smoking. In Western industrialized country, the prevalence of anorexia is about 0.9% of the female population and about 0.1% of the male population. And sadly, half of the cases of anorexia and about a third of the cases of bulimia are never even detected by the healthcare system. We do a terrible job of actually diagnosing these patients with these conditions. And as I mentioned, one of the risk factors that predicts mortality is age at first presentation and duration of illness. So we need to do a better job of actually diagnosing and recognizing these problems. So talking about the medical complications, there's two different kinds. In anorexia, the complications are due to starvation and weight loss or low body weight. These patients are at very high risk of refeeding syndrome. In bulimia and the binge purge kind of anorexia, their medical complications are correlated with the mode and the frequency of purging behaviors. They are subject to electrolyte abnormalities, and they have very stressful detox from purging behaviors. And they are, of course, also at risk for refeeding syndrome because they essentially have gone with no nutrition. The list of medical complications for both anorexia and moving on to bulimia or binge purge anorexia are very long, and they affect every single organ system. Unfortunately, we don't have time to go through all of that today, but just so you're aware that every single organ system can be affected as a consequence of these illnesses. Starting from the top, I wanted to start talking about vital signs because in physicians' offices, these are very routinely checked, and they are very abnormal in these patients. They are almost universal, and it's really the body's way to adapting to malnutrition and weight loss. The body essentially goes into hibernation mode. It tries to consume as few calories as possible to maintain its essential functions, and it does a very good job of doing that. And there's several different things that it does. Number one, the patients become hypothermic, or they have a very low body temperature. The temperature is usually less than 96.8 or Fahrenheit, or less than 36 degrees Celsius. About 22% of patients with eating disorders in the outpatient setting have hypothermia. There's nothing to do for this except either some heated blankets and really nutrition. The second vital sign abnormality is hypotension or low blood pressure, with a systolic less than 90 and a diastolic, which is a smaller number, less than 50. Another about 20% of patients with eating disorders have this. The trick is that as physicians, I don't know how many of you are physicians, any abnormal number, we feel pressure to treat it, and we want to make that number go from red to black, so normalize it. These patients don't need their hypotension treated unless they're symptomatic. So if they're telling you that, hey, when I get up and go to the bathroom, I feel dizzy and I pass out, then the hypotension needs to be addressed. Otherwise, when they're at such low body weight, their blood pressure normally runs very low. It runs similar to what the pediatric blood pressures would run. Bradycardia. Bradycardia is a slow heart rate, anything less than 60 beats per minute. Again, this is another adaptive mechanism. It's due to several things. One, the low body weight. Two, the fact that metabolism is slowed down, so the heart rate slows down as a consequence of that. Number three, there's an increase in vagal tone. The vagus nerve is the nerve that commands our sort of relaxed response. And so it's increased during anorexia, mainly because of the suppressed metabolism. So for those three reasons, the heart rate should be less than 60 beats per minute. On our eating disorder unit here at acute, our average heart rate is about 51 beats per minute. The other vital sign abnormality, the sort of opposite end of this coin, is tachycardia, or a fast heart rate greater than 100 beats per minute. This is due to loss of cardiac muscle. So as the body loses weight and the body loses muscle mass everywhere, the heart's a muscle, and so it shrinks. And what ends up happening is that even things like getting up and brushing their teeth, the heart rate will go from 40 beats per minute to 180 beats per minute because the heart is struggling and it's having to work extra hard. This is not an orthostatic change, and this is not an athletic heart. A lot of patients will tell us, oh, I run 10 miles a day. I'm an athlete. Of course my heart rate is low. Well, the tachycardia can actually be a way to help us reality check the patient. Athletic hearts don't go from 40 beats per minute to 180 beats per minute brushing their teeth. An athletic heart remains in the 40s even with activity. So it's very important. Also, because the standard is that these patients are bradycardic or they have low heart rates, even a normal, quote-unquote, normal heart rate around 70s should make us think that there's something else going on. The body is stressed somehow. Maybe there's an infection, an inflammation, and we should work that up. So bottom line for vital signs is that we do not need to treat asymptomatic hypotension or bradycardia in these patients. They really need nutrition, and they need someone who understands that these vital signs are normal for them. The restrictors, we run the risk that because their heart has shrunk, IV fluids, that's usually the treatment for hypotension, may lead to congestive heart failure. The purgers can also have heart failure, but also because of the mechanism that we'll talk about with constant purging mechanisms or pseudobarter syndrome, they become very edematous very quickly, which is very scary for them and very challenging. Moving on to cardiac complications, really the most common complication is arrhythmias, and they have many different arrhythmias varying from blocks to junctional bradycardia to junctional tachycardia, and we'll talk about a couple of different things that go on. Other cardiac complications that we don't have time to cover are pericardial effusion, mitral valve prolapse, which occurs in about up to 50% of patients with anorexia, and pneumothorax or pneumomediastinum in very extreme cases. So as far as arrhythmias or cardiac, we know that these patients are at increased risk of sudden cardiac death. And they studied this in postmortem biopsies, and they noted that these patients have absolutely normal coronaries. So this is not the cardiac death of the 70-year-old person with diabetes and hypertension that has plaque buildup. That's not why they're dying. So we shifted our thinking in the past to think that maybe these patients are dying because they have prolonged QTs. A lot of EKGs in these patients show that they have prolonged QTs. And so the thought for a while was that prolonged QT was inherent to anorexia. And a long QT can degenerate into things like ventricular tachycardia, ventricular fibrillation, or torsade de pointe, which are all deadly arrhythmias. So what is the QT interval and why is it important? So the QT interval, and I'm going to use the mouse as my pointer, goes from the Q part of the EKG all the way to the T part. And it's a sign of electrical conduction through the ventricles. So when the heart is getting ready to squeeze blood out of the ventricle into the rest of the vasculature. It should be less than 500 milliseconds. Anything greater than that is a long QT. And we now know that it's not prolonged QT is not inherent to anorexia. The problem with the QT in anorexics is that they have QT, what's called QT dispersion. So whereas you and I have the exact same length of the QT in terms of milliseconds from beat to beat, these patients have different lengths of QT from beat to beat, which means it's a very unstable cardiac conduction. And it's a setup for arrhythmias. So QT prolongation is not inherent to anorexia. If we see it, it's due to something underlying like medicines or electrolytes, all the abnormal salts in the blood. But what they do have is this variability in beat to beat or QT dispersion. So how do we catch bradycardia and QT prolongation? Pretty easy. We actually check in EKG. The highlighted part shows us that the rate is 42 beats per minute, which is low. And if you look further down on that EKG read, it'll tell us what the QT, the corrected QT or QTC is. In this patient, it's actually normal. What else do we do for these patients? We check electrolytes, so all the salts in the blood, and we review their med list very thoroughly. This is sort of a list of medicines that are on the naughty list for QT prolongation. It's by no means an exclusive list, and a lot of medicines have QT prolongation as a side effect, so we need to be familiar with it. Unfortunately, a lot of the antidepressants and antipsychotics have QT prolongation as a side effect, and a lot of our patients are on these medicines. So how do we treat cardiac complications? Well, number one, we check in EKG, and we place them on telemetry in the hospital, or we put them on constant heart monitoring. And those electrodes can be pretty fun to take off when the patients leave the hospital. What else do? We check electrolytes. We check a chest x-ray if we suspect anything that's going on in the lungs. We get a thorough med list. And really, we do not treat bradycardia or hypotension unless the patient is symptomatic. And if they do need treatment, it's never bolus of fluids. It's always very slow infusions. GI. These are probably the most common complications that are really the most bothersome to our patients. So starting with gastroparesis. Gastroparesis is delayed gastric emptying or abnormal contraction of the stomach. This occurs essentially in everyone who is underweight and really can start with even a weight loss of 20 pounds. It's an adaptive mechanism because the body is trying to absorb as much as it possibly can from the few calories that it consumes, and so it slows down how long it takes food to transit through the whole GI tract so that it can more successfully absorb nutrients. Excuse me. Symptoms can be things like nausea, early satiety, bloating, flatus, abdominal pain, acid reflux. And this is really hard to tease out because there's such a strong connection between the gut and the mind that a lot of times these patients aren't diagnosed because the providers think that it's due to their eating disorder and not something organic. And it's really a shame because gastroparesis is actually very easy to treat. The radiographic proof is actually a gastric emptying study where the patient eats radioactively labeled food and the radiologist shoots pictures as it moves through the GI tract. It's really hard to get somebody who is terrified of eating to eat radioactively labeled food, number one. Number two, they've already told you that they have all this GI pain, and so we actually don't need it. Here on acute, we hardly ever order gastric emptying study. We really talk to the patients, get a good history and symptoms, and make the diagnosis that way. So you can really avoid expensive and frustrating tests for patients. If you're going to do them, this is what a gastric emptying study looks like, and going from left to right, the stomach is full of food, and as you can see 2 hours later, the bulk of the food is still in the stomach. So this is like eating a Thanksgiving or holiday meal 3 times a day. No wonder the patients feel so full and are resistant to more nutrition. What makes it worse? Solid meals, high fat, high fibers diet, because those are macronutrients that are normally meant to be digested very slowly. Very large meals worsen gastroparesis. And really the reverse of that alleviates it. Liquid meals, low fat, low fiber, small meals, and a short course of meds. What are those? Part of the treatment needs to be weight restoration, but as we get the patients there, some of those medicines are metoclopramide, or also called Reglan, before meals and at night. This is an old nausea medicine, and it acts centrally in the brain, which is really nice because it alleviates nausea, number one, and number two, it allows the stomach to empty faster. If that's not enough, you may add erythromycin or azithromycin. These are macrolide antibiotics, and unlike Reglan, they actually work in the entire GI tract. If you're going to use one or both of these, or a combination of meds, you need to check an EKG because they are all on the naughty list for QT prolongation, and so if they cause conduction problems, they need to be caught. But really, the patient needs a lot of reassurance that their symptoms will resolve with weight restoration. Constipation, again, universal in the malnourished state. It's an adaptive mechanism. The colon moves a lot more slowly due to slowed colonic transit. And number two, there's a reflex hypofunctioning of the colon whenever there's reduced caloric intake. How do we diagnose this? Really, just like gastroparesis, history and physical exam is all that you need. But sometimes to reality check the patients, we get abdominal x-rays to prove that there is stool. A lot of times, again, because the mind and gut are so connected, the patients have all these complaints, but there's no actual stool in there. So how do we diagnose? How does this look? Well, on the left of your screen, there's a colon that has absolutely no stool. The patient was complaining of bloating, fullness, gas, constipation, hadn't pooped in a week. On the right, where the arrows are, it's a different patient who had the exact same complaints. Also hadn't gone to the bathroom for a week, bloated, gas, fullness, discomfort. The patient on the right has a colon that is entirely full of stool. So patient complaints aren't always helpful in these situations because they can have the same complaints with two different pathologies. So how do we treat this constipation? Well, number one, we reassure the patient, we educate them and set expectations. There's a Rome criteria for stools that states that less than 3 stools per week is actually normal bowel function. And so we set that as a standard for the patient. It may not feel good to not go to the bathroom every day, but it still falls within the normal realm. We also make sure that the patients are hydrated and their salts are normal, because bowels move best with a potassium of 4 and normal phosphorus. When we need to, we use osmotic laxatives such as polyethylene glycol or Miralax, and really we try to avoid stimulant laxatives unless there's proof of stool. And what are some of these stimulant laxatives? Things like senna, bisacodyl, cascara, magnesium, citrate. I don't know which ones of you have seen this, but apparently Starbucks has a brand new cascara latte that I'm not sure if the side effect is what we think the side effect is, but it is very popular, unfortunately. So why do we worry about these stimulants? These stimulant laxatives are meant to stimulate the nerves that innervate the colon. So the colon is meant to move like a snake and propel fecal material through it. If the nerves are getting pushed and they're not ready to sort of innervate and they're not able to innervate, there's a theoretical risk that they may actually get damaged and not work again. This side effect was very, very we worried about it in medicine in the 80s, and then we sort of stopped thinking about it, or we've kind of laxed our rules. Unfortunately, here on acute, we have seen a consequence of stimulant laxative use, so we don't use it unless we absolutely have to. And this is the reason why, and I'll show you kind of a gross picture. This is a picture of a colon that we removed from one of our patients because of cathartic colon syndrome. So this side effect of laxatives leads to a colon that when the nerves die, when the nerves don't move anymore, don't work anymore, the colon is unable to move and becomes this floppy tube that can't propel stool. So there's no tapering off laxatives. We just stop them and put the patients on a lot of osmotic laxatives, such as polyethylene glycol, and only if needed do we add stimulant laxatives. Moving on to hepatitis. Hepatitis, simply put, is inflammation of the liver. About 50% of patients with anorexia nervosa have hepatitis. It usually causes no symptoms for the patients, but for us providers, it's pretty scary because it can predict, number one, hypoglycemia, and number two, it's sort of a sign of impending doom. The organs are really suffering. So what happens? In starvation, the AST and ALT, which are the two numbers that we worry about, those are the two enzymes that the liver produces, can be up to 30 times normal. The reason for this is called autophagy or apoptosis. This is programmed cell death. The body is literally destroying liver cells for nutrition. It's really more likely to occur with a low BMI, less than 12. And patients don't need any further workup for this. I can't tell you how many patients we've admitted that have had biopsies or hepatitis workup. They don't need anything. They really need nutrition to start immediately. The second kind of hepatitis that can occur is a refeeding hepatitis, and this occurs a little later on in the refeeding process, and this is due to a fatty deposition in the liver. Unlike the starvation hepatitis, where the liver looks normal and healthy, in the refeeding hepatitis, the liver looks damaged. It looks like there's fatty deposits in it. The treatment for this is to reduce calories, especially dextrose-containing calories, until the liver function improves. So it's very important to distinguish between these two kinds of hepatitis. And how do we do that? Well, number one, really history and onset of disease. The history and onset of starvation hepatitis is very early on in the disease course. And if we need to, we can get serial liver ultrasounds, which we routinely order on acute when needed. We essentially check liver ultrasounds every 2 to 3 days and see what the liver is doing. In starvation, it's normal in size, so there's nothing to do. We continue with the calories. In refeeding, the liver looks large and has fatty deposits, and so we back off on the calories until it appears to be better. Next topic, I feel like this is a hot topic in anorexia these days, is SMA syndrome. This is a very rare complication of severe malnutrition that leads to intestinal obstruction. It was very popular in the surgical literature, but not really in the medical literature. And how does this present? Well, patients complain of abdominal pain and nausea after meals that's alleviated by vomiting. Again, this is a tough diagnosis to make in patients that are purgers because they often have these symptoms because of their eating disorders. And so we need to be aware of this and know how to diagnose it. This is a diagram of what it looks like. So essentially, you see the aorta, and one of the branches of the aorta is the superior mesenteric artery, or SMA. It feeds all the intestines. And as you can see, in between those two arteries is the mesenteric fat. It's a fat pad that keeps those two arteries open and away from each other. Right coming at you from the screen, right where that angle is the duodenum, or the first part of the intestines. And as you can see, if that fat pad is gone, the two arteries are nice and juicy and muscular. They wanna come together, and they essentially compress the duodenum and not let anything pass through. This is more of an anatomical look with some organs in place, but it's the same thing, the aorta with the SMA. And you can see, if you follow the stomach into the duodenum, you can see where it crosses between the two arteries, and it would get compressed. So how do we diagnose SMA syndrome? Well, the gold standard is an upper GI series where you have the patient drink contrast and you follow it through. Well, it's really painful for them because they've already told you they have nausea and pain and vomiting when they eat. So this is sort of a test that they really don't like to undergo. What we use a lot of is a CAT scan of the abdomen. You can do this with IV contrast. They do not need oral contrast. So if you're going to get an upper GI series, this is what it looks like. The stomach is full of contrast. It moves into the duodenum, and then where the arrow is, it abruptly stops because of the obstruction. The CAT scan is much like the initial diagram. You can see that the duodenum is essentially pinched between the aorta and the SMA. There's two different kinds of SMA syndrome. Complete SMA syndrome, where the duodenum is completely compressed between the two arteries. These patients must have a surgical tube placed because there's no other way to nourish them. And this can't be a gastric tube or a PEG. This has to be a jejunal tube. The jejunum is the second part of the intestine after the duodenum. So the tube cannot go in the stomach. It has to go in the jejunum because it has to bypass the obstruction. And unfortunately, we have no idea at what point this will get better. The body will reconstitute the fat pad. It's really a trial and error sort of treatment. We ask the patient, do you feel like trying something oral today? Yes or no, and then we will try and go from there. The good news is that this isn't lethal in the sense of if they try to drink or eat something, it's not going to kill them. It won't feel good, but once they vomit, they should be fine. In complete SMA syndromes, we do not use Reglan because it can lead to acute gastric dilatation, which can be deadly. Incomplete SMA syndrome, which is probably the most common one, it is the most common one, the duodenum is partially compressed, but it's not completely compressed. So liquids can pass where solids can't. And really, in these patients, we have a sit down with them and we ask them what they want to do. They can either do a diet of mainly liquids and soft foods, or sometimes we will put a nasogastric tube, a tube from their nose into their stomach or duodenum, and trickle tube feeds in. And just like complete SMA, we don't know when this is going to get better. It's a trial and error every day. In these cases, we can use metoclopramide or medicines for gastroparesis, and it actually alleviates their symptoms. Moving on to electrolytes, there's two syndromes we'll talk about. One is the refeeding syndrome, and the other is Suda-Barter syndrome. So what is refeeding syndrome? It's a potentially deadly syndrome that occurs as a starved person begins to take in nutrition. We initially saw it with the unintentional refeeding of World War II prisoners that were being released from concentration camps or freed from concentration camps and were going home and dying. The ones that have been rescued by American troops and drank milk were actually doing okay. And so a very astute psychologists wanted to study this. Hansel Keys performed the Minnesota experiment where he essentially took conscientious objectors of the war. This study would never get approved by any COMERBs in any IRB in this day and age. But he took conscientious, healthy objectors to World War II. He studied them for a period of 12 weeks. Then he starved them for a period of 24 weeks. They had to lose 25% of their body weight by diet and exercise. And then he refed them 4 different diets. And he was trying to figure out the pathophysiology of both starvation and refeeding. Unfortunately, he was heavily criticized for this because his results came out in the 50s, and most of the survivors had already died. Then we sort of forgot about refeeding syndrome until TPN was invented in 1969, and as soon as patients were receiving TPN, they were dying. And so then we learned what it was. So essentially what happens is that as a starving person is being fed, the body shifts from a state of breakdown or a catabolic state to an anabolic state, a state of growth. So it goes from using fat as a nutrient to using carbohydrates to rebuild cell. And it goes from tissue destruction to tissue growth. Really, the driving factor of this is glucose, which stimulates insulin, which makes phosphorus and potassium move from the blood into the cells, and as well as glucose, actually. Insulin also causes the kidneys to retain salt and water, leading to the dreaded edema that we see in refeeding syndrome. The full-blown syndrome is actually, it constitutes of heart failure, rhabdomyolysis or muscle breakdown, hemolysis or red cell breakdown, seizures, hypophosphatemia, and eventually death. And this is sort of what it looks like is you're malnourished. The kidneys decrease how much phosphorus they excrete, which normalizes your serum phosphorus. Now you introduce carbohydrates as you're being refed, which stimulates insulin, which makes all the nutrients move from the blood into the cells. There's increased demand for phosphorus to provide the energy-making molecules, which depletes the serum of phosphorus. Eventually, ATP, or the energy molecule of the body, which requires phosphorus, is depleted, and it leads to the full-blown syndrome with hypoxia and cardiac injury and eventually death. The most important electrolyte in refeeding is phosphorus. And there's a few predictors of hypophosphatemia: lower BMI, weight loss greater than 15% of body weight, less than 75% of ideal body weight at the beginning, and really beginning low potassium and low prealbumin, because these patients have, it looks like they're going to be sicker because there's something else underlying their presentation. About 33% of patients that have a BMI less than 13 will have hypophosphatemia, so it's important for us to recognize it and treat it. Low phosphorus causes depletion of the energy-making molecule, which, as mentioned before, leads to all kinds of problems, varying from muscle breakdown to death. So it's important to screen for phosphorus, and we start treatment when it's less than 3. Edema. Edema is probably the worst consequence for patients because they have such bad body dysmorphia that it really is stressful for them. For us physicians, edema can be a sign of congestive heart failure, and that's why it's very scary for us. This has to do with the insulin effect that causes water retention. And really, the important thing to know is that this edema does not require medicines. It requires continued calories and support for the patient. The only time we use diuretics or water pills that will draw water out is when the skin is being compromised. When that happens, we put the patients on diuretics for a few days and then stop them. Who is at risk for refeeding syndrome? These are the nice guidelines that you can pull up online that highlight the patients that might be at risk for refeeding syndrome. Certainly not a slam dunk. Can it be prevented? Yes, with close monitoring and with adequate dietitian input, it can absolutely be prevented. The patients need supportive care, and they need to be treated in centers that know how to recognize these. Moving on to purging and some of the issues with purging. What happens when when a patient constantly purges, whether it's self-induced vomiting, laxative, or diuretics, is that they're volume depleted, so they're dehydrated, and they lose electrolytes. And dehydration can lead to dizziness, fainting, fatigue. The electrolyte imbalance can lead to muscle damage, seizures, arrhythmias, death. So how does the body adapt to this? It starts to increase the production of a hormone called aldosterone by the adrenal gland. Aldosterone makes the body retain salt and water and gets rid of potassium and acid. So what happens is, as the blood pressure falls, the body triggers all kinds of hormones, ultimately leading to increased aldosterone, which makes us retain salt and makes the blood pressure rise. So you go from dehydration to normal volume. Well, how does the body, when a person stops purging, how does the body decrease the production of aldosterone? Well, it takes a few weeks because it's a hormone, so the downregulation takes some time. But the patients must stop purging. We need to give them adequate volume, and the electrolytes must be corrected. So we need to take away the stimulus that's driving this production. And unfortunately, what happens is that on cessation of purging, the edema that can ensue can be very rapid and very severe. And when these patients present to the emergency room and are given aggressive fluids, they retain everything because the body has so much aldosterone on board that it's retaining all the salt and water that it's given. So how do we combat that? Interestingly enough, we give a diuretic to combat diuretic abuse, a very specific diuretic called spironolactone, which is an antagonist of aldosterone. It's not a great diuretic. It also increases potassium, and it gives very little diuresis. So we use it for 2 weeks in doses of 50 to 200 milligrams, and really extensive counseling on the part of the patient. And aldosterone works right here, spironolactone works right here to block aldosterone. This doesn't mean that the patients won't get edematous, but hopefully it'll be a less severe kind of edema. Lastly, we'll touch on endocrine issues. So the number one endocrine issue that is scary for the sort of acute care of these patients is hypoglycemia, so glucose less than 60 that can present with sweating and dizziness and confusions, really all the way to arrhythmias and death. The scary thing is that these patients may be asymptomatic when they're hypoglycemic, which really makes intervention much more difficult. But we need to screen these patients at each visit. Why does hypoglycemia occur? Because the body stores glucose as glycogen in the liver, and during starvation, glycogen is broken back down and released into the vasculature as glucose. Well, when those stores run out, there's nothing that the body can do, and so the glucose level drops. And again, hypoglycemia may lead to anything from a change in mental status or fatigue all the way to death. How do we treat this when it's less than 60? We sometimes put patients on a glucose drip, or we trickle in tube feeds if the patients allow us until the glucose normalizes. They really need not only glucose, they need protein and fat to maintain an adequate glucose level. The next endocrine abnormality that we'll talk about is osteoporosis. Osteoporosis occurs in a lot of these patients, unfortunately, and osteoporosis is loss of bone mineral density. This is one of the potentially irreversible complications of malnutrition. It really increases the risk of lifelong fractures. We look at two different things, T-scores and Z-scores based on DEXA studies. T-score compares bone mineral density to healthy young adults. We use it in postmenopausal females and males greater than 50, the people that you would think have osteoporosis. In the majority of our patient population, we use Z-scores, which compares bone mineral density to age-matched controls. And how do we diagnose this? Well, this is based on DEXA results. Osteopenia or mild loss is a Z or T score between -1 and -2.5, and osteoporosis anything less than -2.5. Why does this occur? Because peak bone mass really occurs in the second decade of life, and that's when patients that's when their eating disorder manifests itself. So these patients don't ever reach peak bone mass. Then they don't have estrogen because they stop menstruating, and the lack of estrogen leads to bone resorption. And then number 3, they have no building blocks to form new bones. And this can be very, very quick. The onset is about 2.5% per year. Not seen in bulimia, probably because they maintain a normal body weight. And these statistics are scary. I mean, 25% of adolescents with an eating disorder or with anorexia have osteoporosis. Their lifetime risk of fracture is 60% higher. And these are young patients that want to be active, and so we really need to recognize it and treat it. What is the gold standard of treatment? It's weight restoration. And a Spanish study proved that. Patients that gain weight by 20% increasing in weight at 2 years gained bone density of 2 to 5%. The scarier statistic is that the non-gainers lost 1 to 4% of bone density, so it's continued loss. We should make sure that their calcium and vitamin D are repleted, but while they weight restore, what can we do? For a long time, these patients were getting prescribed oral contraceptive pills, but really what we know now is that they don't work, and they actually lull patients into a false sense of security because they think they have a period and they're healthy. There's now data for transdermal use of estrogen. It has to be coupled with progesterone, but no oral estrogen works for osteoporosis. Bisphosphonates are great medicines. They're used in older patients, but they've been studied. They're the best studied medicine in anorexia. They can improve up to between 2 and 4%. These are, of course, patients of childbearing age, and bisphosphonates can affect fetal calcium and fetal bones. So these patients need to be extensively counseled on the use of bisphosphonate and really good birth control while they're on it. These two medicines are teriparatide and denosumab. Teriparatide has been studied in anorexia. It does increase bone mineral density. It's an injection given every 2 years, so patients aren't really agreeable to it. Denosumab, or Prolia, is an antibody that also stops bone destruction. It has never been studied on anorexics, but it's an injection given every 6 months, so it's really appealing. How about exercise? While underweight, it's absolutely terrible for these patients. The action of the tendon on the bone actually weakens their bone. Once weight restored, it's absolutely helpful. It can rebuild their bones. So we tell them that exercise is a privilege of recovery. Men have greater loss of bone density than women do, probably because their diagnosis is even later than women's, and they actually fracture at higher bone mineral density. So men also have osteoporosis. How do we treat men? A little differently. We check the testosterone level. If it's low, we treat their osteoporosis with testosterone. If it's normal, we treat with bisphosphonates or any of the other medicines as for women. So really, we need to check a DEXA within 6 to 9 months of cessation to diagnose cessation of menses to diagnose osteoporosis, or 9 to 12 months of the diagnosis of AN. And this is a list of medicines that are helpful for them. These two next slides are really criteria for when these patients need a higher level of care for the restrictors as well as for the purgers. And I just wanted to talk about sort of the levels of care. Really, the patients that we treat on acute are patients that are less than 70% ideal body weight. We're under the medical benefit of the insurance company, which is really nice because they stay with us 2 to 3 weeks, and then their outpatient or their inpatient psych all the way down to outpatient psych can keep all the really precious psych days for continued treatment. And who we are, we're a 16-bed unit. We take all genders, 17 and up. We have an amazing multidisciplinary team composed of psychologists, and Dr. Lashen will talk about some of the interventions she does on our patients. Our psychologists see the patients 5 days a week, as do our dietitians. All our physicians, nurses, and CNAs are specialized. We have a whole dedicated team of social workers that really help the patients transition from us to a treatment center of their choice. And really, now Dr. Lashen will guide us through the psychological complications that are sometimes barrier to treatment in these patients.
Thanks so much, Dr. Mascolo. Hi, everyone. I'm Dr. Gillian Taylor Lashen. I'm the lead clinical psychologist here on acute, and I'm going to be talking with you about the psychological complications of eating disorders. So just briefly, I want to review just a few quick objectives. We're going to talk about how to help a loved one or a patient you may be working with on an outpatient basis make the choice to enter treatment or step up levels of care. We're going to review some of the emotional challenges that patients are confronted with when they're beginning treatment or entering treatment. And we're going to talk about the do's and don'ts, if you will, about how best to support a loved one or a patient who has an eating disorder. And we're going to specifically be talking about those with severe eating disorders, since that is largely who we treat here on acute. So Dr. Mascolo did a great job of outlining a lot of the ways in which we can look for signs and symptoms of eating disorders from a medical perspective. And so once it's been established that clearly someone has medical complications or psychological complications for that matter of their eating disorder and needs to enter treatment, it can be really important to support them in making the decision to move forward and actually go into treatment. But that can sometimes be a difficult conversation to have. So a few thoughts about how best to do that. So the first one is being mindful of time and space. And when we're talking about time, we want to make sure that when we're sitting down and talking with our loved one or our patients about their eating disorder and the need for care, that we're not rushing, that we haven't just had an argument or emotions aren't running high, but it's the right time to sit down and have a productive and meaningful conversation. We also want to be mindful of space. So we want to be somewhere it's safe, quiet, without a lot of distractions or interruptions, because this is going to, again, help us have the most productive conversation possible. And so it's important to be forthright and compassionate, to really be straightforward and honest with your loved one or your patient while also being empathic. And sometimes that can feel like a tricky balance to find. And so one way to do that is to really rely on objective observation, concern, and then question. So an objective observation might be something like, I've noticed you've been losing weight, or I see you go into the bathroom after each meal. It's not going to be something like, I know you're purging, or wow, you've gotten so thin, or you're just trying to lose all this weight. We don't want to make assumptions. We don't want to be blaming. We just want to offer an objective observation. And then we want to follow that up with a concern. I'm concerned you might be relapsing. I'm concerned you might be purging. And then come at it with a question at the end. How can I help? Help me understand what's going on. What should we do next? What do you need from me? So that opens it up, so it makes it a dialogue and engages the patient or the loved one and kind of puts the ball in their court so that they can be heard and let you know where they're coming from. Because shame and stigma can be such prominent barriers to seeking care or stepping up levels of care, it's important to be sensitive to this when we're having these discussions. Studies have reported that people with eating disorders are more likely to be blamed for their disorder and to be perceived by others as using their illness as attention-seeking. And this is sort of consistent with the misconception that eating disorders are often, a lifestyle choice. And so we have to be mindful of that can be a barrier to people wanting to talk about entering treatment or being willing to actually follow through with entering treatment. Another prominent barrier can be poor insight or just the patient sort of minimizing what they're going through. So some patients just fail to perceive just how severe their illness is, or maybe they don't consider their eating disorder behavior to be a problem. And this is, again, where that sort of objective medical evidence can come in. So again, some of the great vital signs and lab abnormalities that Dr. Mascolo educated us about can be helpful to sort of send the message of just how severe someone's eating disorder is or how concerned you are about them, and then come to this discussion with a plan. So again, we're opening it up, we're asking our patient or loved one, what do they think, what do they need? And if they aren't able to generate any ideas, then we want to present some. Here's some treatment centers I've looked into, here's a provider I think we can talk to, here's an intake team that's waiting for your call, whatever it may be that you've done in advance to help them move the process forward. So when we're providing psychological care for folks with severe eating disorders, we want to be really sensitive to the fact that they are often feeling overwhelmed and anxious because they're adjusting to the new setting and structure of treatment. They might be away from home or family, so this can be a difficult time. Immediately upon entering treatment, typically, patients are faced with a significant source of stress and fear, and that's food. So we have them start eating right away. So often patients will start at a lower calorie level for their meal plan when they first admit, but nonetheless, they're having to eat, and that can be really difficult. And I find patients often enter treatment with the belief that if they eat any more than they were prior to entering treatment, which was typically very, very little food, that they're going to gain weight. And so it can be powerful and educational for them to go through the treatment experience and see that they can actually take in considerably more food than they thought they could without really gaining much weight, or certainly not without ballooning up, which tends to be their fear. So there's a lot of shame and guilt that can go along with entering eating disorder treatment. Often patients for the first time might be truly admitting that they have a problem, and that can be difficult. there's oftentimes feelings of ambivalence as well. And so ambivalence we think of as having sort of mixed or opposing feelings, love, hate, both positive and negative feelings. And this is not at all uncommon for folks with eating disorders. They might be aware that their eating disorder is a problem, but they're still fearful of life without it. And so they come with this ambivalence, and that's something that we're empathic towards, and we kind of work to counsel them through. We also know that patients first entering treatment or while they're still medically stabilizing might have labile mood. This tends to be a consequence of starvation and medical instability. I tend to talk with my patients about how being hangry is a real thing, so that idea that we get so hungry we're angry. And sometimes that's sort of the first connection they're making between what they eat or don't eat and how they feel emotionally. And then finally, we're also looking out for low frustration tolerance. Oftentimes patients have either poor coping skills just in general, or sort of their only coping skill was their eating disorder, and now they don't have access to that. So they might feel overwhelmed emotionally, and that can lead to sort of a short fuse, which we understand, and again, we're just trying to provide support for them. So here on acute, we practice what's called supportive psychotherapy. There's unfortunately a dearth of empirical research regarding the efficacy of specific therapies in severe eating disorder populations, but there was one randomized control trial that showed that supportive psychotherapy tended to produce better outcomes over CBT, cognitive behavioral therapy, or IPT, interpersonal psychotherapy. So because of the efficacy in eating disorder and medical populations, we find it to be a good fit for our folks here on acute. Supportive psychotherapy focuses on three main areas: self-esteem, and the way in which we sort of try and build this and reinforce that for patients is using evidence-based praise, appropriate reassurance, encouragement, so sort of normalization of things. And I am always impressed with how far praise can go in this population, even in adults. So we tend to think of praise and reinforcement as being things that we might offer younger children. But if we think about how challenging it is for folks to enter treatment when they have a severe eating disorder and start giving up those behaviors, they really find that praise is helpful. Again, we try and do it in a developmentally appropriate way so they don't feel childlike, but really acknowledging their efforts and then telling them they're doing a good job can help to restore their self-esteem. We're also looking at ego function or psychological function, and with supportive psychotherapy, we use a lot of rationalization or reframing. We're helping patients label and identify feelings or name problems. We're helping them clarify their thoughts. We're using perhaps gentle confrontation and some interpretation as well to build that psychological function. And then finally, we're focusing on adaptive skills. So we're helping them prevent or manage anxiety that might show up. We're helping model and teach problem solving, and also offering some guidance through the different challenges they face as they go through their medical hospitalization. And that's really overall the goal of supportive psychotherapy, is to reinforce the patient's ability to cope with the stress associated with hospitalization. So the nice thing about supportive psychotherapy is it's flexible. It allows us to meet patients where they are at, both sort of literally and figuratively. So literally in the sense that we come right to their room. We're able to do supportive psychotherapy at the bedside, which is often indicated for some of our patients. And it also allows for variation in the intervention. So some of our patients have more cognitive impairment from their starvation than others, and so we can kind of meet them where they're at in that sense. We can also meet them at where they're at in the sense of like, what's going on that day? So maybe they had a meal plan increase and that's particularly stressful for them. Maybe they got back their bone density results and they're upset that they have osteoporosis. Dr. Mascolo talked about some of the psychological effects of edema, that it's really difficult for our patients and their body image. So we often are going to meet them where they're at and talk about those different day-to-day issues. Initially, we do conduct sessions in room, like I mentioned, to account for the fact that our folks have low stamina and energy and are often medically compromised. But as their stamina increases, we can move sessions to the treatment room and we might make them longer in duration. So we use active listening to help patients cope with stress and sort of express their thoughts and feelings in service of helping them gain a broader understanding of what's going on, what the situation is, and what their options are. And we really want to use supportive psychotherapy to help increase resilience in our patients during treatment and also instill hope, which is so important because, again, coming back to that shame and guilt patients can feel, we really want to help them sort of see that things can get better for them. So as patients improve, which is really fun to see, they get stronger, their brain is kind of coming online, and they're more engaged, then we might move to some of what we think of as more cognitive or behavioral-based therapies like cognitive behavioral therapy, dialectic behavioral therapy, or acceptance and commitment therapy. Some patients, however, will continue with supportive psychotherapy throughout their hospitalization, and that usually works well too, and that just might be where they're at. We don't run process groups or traditional group therapy here on acute due to, again, the sort of cognitive distortions or impairments that folks that are so severe and medically unstable might be experiencing. That emotional lability often makes it difficult to really productively engage in a group. And we really want to focus on positive influences for our patients. And occasionally at this high level of care when folks are still quite ill, they struggle to influence one another in a positive way. And for our patients here on acute, if they have a trauma history and it happens that their trauma is activated at some point during their stay, then we work on skills to help them manage that distress, so things like grounding and self-soothing. But trauma work is not the focus of the sessions, again, because the folks here on acute tend to just psychologically not have the resilience and the skills necessary to do such intense work as trauma work, and also because trauma work tends to be done on a more longitudinal setting, and we just can't really do it justice with our more acute stays here on the unit. So finally, what can you do, whether you are a medical professional or another type of unit sort of professional and you're seeing patients in the community, or you're a loved one and you're concerned about someone who might have an eating disorder, you can offer a safe space to express emotion and fear. That's so important, and that's a lot of what we're doing with supportive psychotherapy here in acute, and you can do that as well. And remembering that your loved one or your patient likely feels threatened and scared by the prospect of entering treatment, again, because they sort of frame it as they're giving up their eating disorder, they're letting go of what might be a coping mechanism for them, or an avoidance strategy might help them feel safe. So they need a lot of support through that process. It's important to not give up, because sometimes it doesn't take one conversation or two or even three, but sort of multiple conversations over time. And sometimes, patients need to just first sort of hear the idea of entering treatment, and there's sort of, need time to contemplate it, and really over time move to a place where they're ready to actually take action. And while you're going through that, or why a patient is contemplating entering treatment, it's important to continue to monitor safety. And again, Dr. Mascolo gave us a lot of markers we can be looking out for and things that we can be doing to keep our patients safe when they aren't in the hospital. And I think it's important too to set some non-negotiables, hopefully collaboratively with your loved one or patient, but asking questions like, how will we know when you need to go to the hospital? And how will we know what will happen? What symptoms will you have when we know that you need to step up to the next level of care or enter treatment? Those are important conversations to be having as well. And then just always coming back to support. That is what our patients and loved ones need more than anything. Those with anorexia tend to be very high in persistence, and so we need to be as well. We need to keep the conversation going and try and avoid taking things personally. So if our loved one or patient tells us no or shoots us down when we try and talk about entering treatment, we need to come back with empathy and compassion and keep that conversation going. So I think we can move on to questions.
Thank you, Dr. Lashen. That was awesome.
Pleasure.
Yes, thank you so much, Dr. Lashen and Dr. Mascolo, for your excellent and very informative presentation. And yes, to all our attendees who are currently with us, we are now transitioning into a Q&A period. So if you have any questions at all that you'd like to ask either of our amazing presenters, please feel free to type it into the question pane of your control panel, and I will be reading those out loud. Also, I am making available in the chat box of your control panel, you should be able to see in just a second here, the link to our CE evaluation form, which you can completely fill out online. So please make sure to fill that out in order to receive your CE credit for tonight's presentation. So let's transition over to our questions. And ladies, first question we have is, can you please speak more about outpatient therapy for eating disorders and what you'd recommend? What are your thoughts on Fairbairn's CBT-E?
I can go ahead and take that one. I think that
Thank you.
yes, of course. I would say, generally, outpatient therapy for eating disorders is great, assuming that's the right level of care for whomever has the eating disorder. There's a lot of good work that can be done. And I don't know that, like I mentioned, that I would say that there's one approach that's better than another. I think that, unfortunately, there isn't a ton of research that shows which approaches work best for folks with eating disorders. There is some evidence for acceptance and commitment therapy. Obviously, we use supportive psychotherapy here on acute, but I think far and away the most important thing in seeking outpatient treatment is having someone who's experienced and knowledgeable about eating disorders and who is experienced and knowledgeable about whatever approach they use, because that's when you're going to get the best results. And unfortunately, sometimes folks that are wonderful generalists tend to lack some of the important information or understandings of eating disorders, again, especially severe eating disorders. So it can be tricky sometimes to find outpatient providers depending on what area of the country you're in that do specialize in eating disorders, but that would first and foremost be my recommendation.
Wonderful. Thank you for addressing that, Dr. Lashen. Another question here. What weight does the patient need to be to benefit from CBT?
That's difficult to say. I don't know that we can put a number on it because, what we see here on acute is that we can have folks that are down into the 50s in terms of percent IBW or ideal body weight. And cognitively, they're tracking fairly well, all things considered. And then we can see folks that are maybe higher in the 60s and 70s, although that's still certainly very low, and they're just having more cognitive impairment. So there's a lot of factors that go into assessing what level someone's at cognitively and what they could benefit in terms of approach. I think, in particular, folks that are struggling with what we might think of as thinking errors, so all or nothing or minimizing or black and white or catastrophizing, those folks are going to do well with CBT and benefit from some of the tenets of that approach. But there's a lot of other great approaches as well, and I don't know that I can put a number on who would do best at CBT at what weight. But because it is a cognitive behavioral therapy, you do need someone who, again, is tracking pretty well and able to engage in sort of being able to reflect on their own thinking, reframe thinking, and make changes accordingly.
Thank you so much for that response. Another question from one of our attendees: what recommendations would you have for a parent of an adult child who recognizes that she needs inpatient care but cannot afford it or refuses to seek further treatment?
So, a parent of an adult child and the adult child refuses to seek care or they can't afford it. Am I understanding that correctly?
Yes, who recognizes that they need inpatient care but cannot afford it or refuses to seek further treatment.
So those are two separate issues, both really challenging. And I can, coming back to kind of what we talked about briefly in the presentation, if someone's refusing to seek care, then I think we have to just keep expressing our concern, our objective observation, and asking questions, engaging them as much as possible, and engaging, hopefully, the outpatient team that they might have or any other providers that the parent can access. So perhaps there's a medical provider that can sort of review labs and offer some psychoeducation or medical education to the patient that way. Sometimes a parent can reach out and begin the discussion with a treatment center by starting the intake process, so typically the patient will need to engage at some point. So I think it's really about creating a dialogue and help figuring out, well, what are the barriers? Is it shame and guilt? Is it poor insight? Is it fear? And seeing how you can best help your loved one sort of through those barriers to see that they can actually feel better and life can get better if they can go ahead and enter treatment and at least give it a try.
Great, thank you so much. Another question here. I'm working with a patient with a BMI 12. We found a placement for her. What would be the medical risk of flying a patient with such a low BMI?
I can take that one. So really, a BMI of 12 does not meet criteria for inpatient psychiatric care. The patient should be seen in an inpatient medical facility like acute, the risk is too high of all the medical complications we went over. But really, they should be seen by a physician, say an internist or a primary care physician, and have at least a vital signs checked, an EKG, and basic labs drawn to make sure that the patient is able to fly across the country. I hope that answers the question. Yeah, it's very dangerous to fly with a BMI of 12. And if for those of you that would be interested in something like this or treat patients that are so sick, at acute we do have a partnership with an air ambulance company called Angel Med Flight. We're able to air ambulance patients from all over the country to us. So my advice would be that your patient go to a local hospital, get admitted, and for them to be flown to us.
Great, thank you so much. Another question here, what is your best recommendation for someone not medically in danger of needing inpatient who is active in their eating disorder but in denial?
Sorry, repeat that?
What is your best recommendation for someone not medically in danger of needing inpatient but who is active in their eating disorder and in denial?
So if they meet inpatient medical criteria and they're active in their eating disorder, they do need to seek treatment. And as far as convincing them, I think Dr. Lashen can address it. My answer would be that if a patient meets inpatient medical criteria, then they are medically compromised. There is something that's medically compromising them. If it's the inpatient site criteria, then maybe Dr. Lashen can speak to how to engage them to go into treatment.
Yeah, I think it would be probably similar to what we spoke about with the other question, the parent of the adult child, in terms of keeping the conversation going and not giving up and not taking no personally, but also not taking no for an answer, and engaging those around you, family members, loved ones, medical providers, mental health providers, whomever you can sort of rally to help support you and to help keep that conversation going with the patient as well. I think that it's just an ongoing process sometimes, and we have to be patient, but also persistent.
Thank you so much, ladies. Another question here. What are the main risk factors, medically speaking, that therapy clinicians should look for to recommend hospitalization or for the patient to, to be, I think, referred to a medical doctor ASAP?
Yeah, so I would refer to the two slides on hospitalization for both ANR, ANDP. So those are some fairly good criteria. So things like hypothermia, bradycardia, hypotension, liver function abnormalities, any kind of arrhythmia, any rhythm that's not sinus, any QT prolongation needs to be seen in the hospital, severe constipation or severe constipation on detox from laxatives, rebound edema, high risk of refeeding syndrome, hypoglycemia, all those are indications for inpatient level of care.
Thank you so much. And another question, are you taking on the unit kids that are severely underweight due to ARFID?
We do take ARFID, but we take 17 and up. So on acute, we are all internists, so we take care of adults. But we absolutely take anyone that has severe malnutrition or a complication of severe malnutrition.
Great, thank you.
Mm-hmm.
Another question, what are the implications of POTTS and chronic ED or POT?
The implications of POT syndrome and chronic ED. So, yeah. So those are two very distinct things. So POT syndrome or postural orthostatic tachycardia. So this whole syndrome, can be seen in patients with eating disorder, but it's actually a syndrome in itself that has nothing to do with an eating disorder. What ends up happening is because of the changes from bradycardia to tachycardia in severe malnutrition, these patients are often misdiagnosed with POTS syndrome. And so they have pacemakers implanted, or they get on medicines that are stimulants, and they don't really need it. So you can have POTS and an eating disorder. The majority of the orthostasis and tachycardia and bradycardia that you see is a direct result of the malnutrition.
Thank you, doctor. And a follow-up to the RFID question, where would you recommend that children under the age 17 go? Is there a place like acute for children and adolescents?
I wish there was. Unfortunately, there isn't. That's actually not my area of expertise, so I am unsure who to recommend for children and adolescents.
Yeah, a local children's hospital might be a place to
a
to
lot
start,
of them.
perhaps. Yeah.
In general, pediatricians are a lot better than internists at treating eating disorders. They see it a lot more than internists do.
Thank you, ladies. We have a question here. Do you have information on estrogen effect on growth plates? I have a pediatrician that wants to use estrogen for young girls with amenorrhea. I've had a hard time getting her to wait. Do you have any studies that she might be able to share?
Yeah, so estrogen, so in order to start estrogen on females for their osteoporosis, we need to make sure that their epiphyseal bones are closed. So before starting treatment, you can get a wrist x-ray that will tell you if the plates have closed. If the plates have closed, you can safely use estrogen. If they've not closed, then you cannot.
Thank you. And
Sure.
we have just a couple general questions about the admission process. Is there somewhere that someone can, or an email address or contact information if people are interested in learning more about the admissions process for acute?
Absolutely. So you can look us up on our website at acutecenterforeatingdisorders.org. And actually, my last slide, thank you for doing that. The last slide has our contact information. So acutecenterforeatingdisorders.org, that's the website for acute. Any admission, and I think one of the strengths of our program is that our intake team is phenomenal, and if we are unable to help your patient, they work really hard at trying to help you troubleshoot and see what other resources are available, other centers, if the patient doesn't have funding, look at free resources, all kinds of things. And the number to call for that is 1-877, the letters acute, ACUTE, the number 4, and then the letter U. Another maybe easier website is acuteinfo@dhha.org. So acuteinfo@dhha.org. But my email is on this slide, and Dr. Lashen's email is on it as well, and I think either one of us would be more than happy to help answer any questions or direct you to someone that can better answer your questions.
Absolutely. And I would just want to agree with Dr. Mascolo that our intake team here at Acute is wonderful. And because it came up a couple times in the questions, this idea of how do we get loved ones or patients that are resistant, give our intake team a call if you think your loved one or patient might at all meet criteria for acute. Oftentimes, patients or prospective patients need to be able to ask questions and learn more about what can they expect and what will they eat and what will they do. And our intake team is fabulous at answering those questions and helping patients perhaps feel a little more comfortable with coming into treatment. So that would be another way to help a resistant loved one or patient.
And also if the patient, thank you, Dr. Lashen. Also, what the intake team can do is if the patient meets criteria for an area ambulance, they can arrange everything. And, time is of the essence in a lot of these patients, and there's already so much anxiety and frustration and fear of coming into treatment that the intake team can really help alleviate all that and make the process very smooth.
Wonderful, thank you. And we have just a couple more questions, if that's okay.
Sure.
Um, Thank you for all the participation. So one of our attendees is wondering, can you repeat why phosphorus is the most dangerous electrolyte change in refeeding?
Yeah, so it all has to do with the insulin effect. And the reason phosphorus is so important is that phosphorus is one of the sort of building blocks for energy molecules like ATP, like 2,3-DPG. And when you have low phosphorus in the body can't produce those energy molecules, and the energy molecules can't feed things like muscles, so the diaphragm and the heart and the brain and anything that has muscle tissue in our body. So phosphorus is the most important.
Thank you. And just a final question to wrap up for tonight. When dealing with the adolescent female athletes that have amenorrhea and BMI less than 18, can you please repeat what you stated about exercise recommendation?
A BMI less than 18?
Yes.
Yeah, absolutely. So with osteoporosis and a low BMI, exercise actually is more harmful. So it leads to more bone loss. There's something that it has to do with the action that the tendons have on the actual bone itself. So as the muscles are being exercised, the tendon, that's the part that attaches from muscle to bone, pulls on the bone even farther, which makes even more sort of material being reabsorbed from bone. So when a patient is at low weight and they have osteoporosis, they cannot exercise. Once their weight restored, even moderate exercise can really help with their bones, but they have to fully weight restore.
Great, thank you. And I'm sorry, we do have one last question. Is there any criteria that uh, would eliminate a patient's possibility for coming to acute?
Is there any medical complication that would?
Yeah, or any certain criteria that, like we have somebody asking specifically about BMI, if a BMI.
So we take care of BMIs less than 15. However, we will take someone at a little bit of a higher BMI if they have, say, binge purge kind of anorexia and need a detox from laxatives or diuretics or their purging behaviors. So we will consider higher BMIs based on the complexity. We also consider higher BMIs if the patient is at a bit of a higher BMI but hasn't eaten anything, so is at risk of refeeding syndrome. The other nice thing about acute, and I don't know how many people know this, acute is housed in a level 1 trauma center in the heart of Denver. So we have all medical and surgical subspecialties available to us day and night. So it's easy for us to get labs and testing and gastroenterology to see our patients and cardiology to see our patients or surgery. So really we have a lot of specialists available to us, and we're able to handle very high acuity. Really the only time the patient, and Dr. Lashen, you can correct me if I'm wrong, would really not be safe to travel to us is any active suicidal ideation, and that's more of a travel issue. They're unable to safely travel to us, regardless of the air ambulance.
Yeah, I would agree with that. There's much that we can accommodate here on acute, but because we aren't a psychiatric unit, someone who is actively suicidal, that would be a safety concern, and you know, our patient's safety is of the utmost importance. So that would be someone who likely wouldn't be appropriate for acute, or someone who is actively engaging in severe self-harm. But really, those are sort of the only two psychiatric sort of limitations. Otherwise, we can treat and work with just about anyone.
Great. Thank you so much, ladies, again, for this fantastic and very informative presentation. We just so appreciate your time and all the work that you have both contributed to the eating disorder community. So thank you again. And to all our attendees who were able to join us tonight, thank you for your time, your attendance, and your participation. Again, if you have not yet accessed your CE evaluation form, link is in the chat box of your control panel. So please make sure to access that and fill it out and submit it for your CE credit for this evening's presentation. If you're in need of any further eating disorder resources, please feel free to check out eatingdisorderhope.com. We also have great information there about our professional membership and our upcoming webinars. We do have another presentation scheduled with Acute at the end of this month that we hope you can join us. So please feel free to check that out and register for our next webinar event. So on behalf of Eating Disorder Hope, our presenters, and Acute, we thank you again for joining us and wish you all a wonderful evening. Thank you.
Thank you.
Thanks.